Hi everybody. Today we'll be talking about the development of the pharyngeal apparatus, the face and the neck, and this is going to be part 2, which goes with Tuesday's lecture that dealt with the description of the pharyngeal arches and the development of the face. So today we'll talk about the development of the tongue and the palate. I'll define the rest of the components of the pharyngeal arch apparatus. So we'll show some examples of clefts, show what they give rise to, and talk about some of the problems. We'll show examples of the pouches, what they give rise to, and talk about some of the problems. And then we'll talk about some of the accessory glands of the neck, particularly the development of the thyroid, and then we'll end with discussing some of the problems that can happen as the thyroid matures. So we'll start with the development of the tongue. So it's important to remember that we're looking now at the floor of the arches. This cartoon is color-coded so that you can see which arch contributes to what part of the tongue. So arch 1, shown in green, is going to form the anterior 2/3 of the tongue epithelium. And arch 2 essentially gets covered up as arch 3 grows over it. So arch 3 is going to form then most of the rest of the tongue, that latter posterior 1/3. And arch 4 forms a little bit of the tongue just at the very back part of the throat. So let's go over this in a little more detail. So starting at about 4 weeks, arch 1 is going to form this median swelling called the median tongue bud. Sometimes it's called the tubercular impar as well. Around 5 weeks, we start to see lateral swellings, or these distal tongue buds, or the lateral lingual swellings. And again, these are going to become the anterior 2/3 of the tongue. Also starting at around 4 weeks, arch 2 is going to form a midline swelling that's called the copula. But then that copula and the rest of arch 2 gets overgrown by the hypopharyngeal eminence, and this is coming from arches 3 shown in purple and arch 4 shown in blue. And together, 3 and 4 are going to give rise to the posterior 1/3 of the tongue. The epiglottis, which you can see here, is the most posterior structure, and that's going to arise posterior to that hypopharyngeal eminence. So to sum up the development of the tongue, arch 1 is going to form that anterior 2/3, arch 2 gets covered up, and arch 3 forms most of the remaining part, that 1/3 of the tongue epithelium. And recall that this epithelium is going to be endodermal because it's in the inside of the pharynx. So the tongue muscles arise from occipital somites. So they're not pharyngeal in origin, and this becomes important. And the only one that is pharyngeal in origin is that palatal glossus muscle. So what do we know about the innervation of the tongue? Well, it's innervated by 4 different cranial nerves. Cranial nerve 5, which is going to bring sensory information to that anterior 2/3 of the tongue. Cranial nerve 7, which is important for taste, also in that anterior 2/3. Sensory and taste in the posterior 1/3 is going to be covered by cranial nerve 9, and then cranial nerve 10 will be sensory, but again, just that little bit by the throat. The tongue muscles, on the other hand, are innervated by cranial nerve 12, the hypoglossal nerve. So anytime you see the word gloss or glossitis or glossal, you want to be thinking tongue. And here I've shown you in yellow the tongue muscles on the bottom and then their corresponding cranial nerves there on the top. So if we think about that innervation, here's another diagram showing essentially the same thing. Again, that cranial nerve 5 is going to innervate that anterior 2/3, which is that first pharyngeal arch. And we have cranial nerve 7, cranial nerve 9, and cranial nerve 10 as we move more posteriorly. The red lines here represent the terminal sulcus. So this is a groove. It's essentially the dividing line between the oral and the pharyngeal tongue. And it's also roughly the dividing line between the anterior 2/3 and the posterior 1/3. And so this is going to be between that cranial nerve 5 and cranial nerve 9 innervation. The only exception to this is those circumvallate papillae, which are innervated by 9, but they're actually anterior to that sulcus. The other important anatomical marker here is that foramen cecum. So this is right at the midline at the very back of the tongue. And that's really important because it's going to be the site of the thyroid primordium. So that's the development of the tongue, and the development of the tongue is critically important to the development of the palate, which occurs between 5 and 12 weeks. So there's 2 parts to the palate: the primary palate, which arises from the median palatine process, which is itself a component of the median nasal process; the secondary palate, which is comprised of the so-called palatine shelves, which are essentially outpocketings from the maxillary arch. So here in cartoon form, we can see the beginning of palate development. So we begin to have those palatal shelves developing. These are called the lateral palatine processes, and they again arise from that maxillary process. And they start by growing down alongside the tongue. So they're actually moving straight down beside the tongue. And this is important because the palate obviously has to form the roof of the mouth, but at this point, they're still growing downward. So what happens to make them grow upwards? Well, they actually flip. So they reorient from vertical to horizontal, and this is due to a couple different things. So one is the growth of the mandible and the oral cavity in general, but the most important part that allows them to flip up is the movement of the tongue. So the tongue's actually going to move anteriorly and inferiorly, so it has to get out of the way in order for those shelves to actually flip up. And then finally, we have a fusion of those two shelves at the midline, and that's going to help us produce our separate nasal and oral cavities. So again, those two palatal shelves are going to meet and fuse, grow towards each other, and then meet and fuse at the midline. At the same time, the nasal septum, which has been growing down, that developing nasal septum, is now going to meet those palatal shelves, and it's also going to fuse with those shelves. So I wanted to go back to Tuesday's lecture and talk about the Pierre-Robin sequence, and this time I'm giving it its proper French name. So if you recall, this is the hypoplasia of the mandible. So this was a result of a problem with the neural crest. But what it leads to was the misplacement of the tongue. And I just told you that the tongue has to move anteriorly and inferiorly, has to get out of the way for the palatal shelves to actually flip up so that they can fuse together to form the palate. And because the tongue is misplaced, the shelves don't fuse, so they can't actually flip up, and this is why these patients have cleft palate. So I want to just briefly describe the differences between the fusion of the facial processes, or merging, and the fusion of the palatal shelves. So as I told you on Tuesday, facial merging is essentially eliminations of furrows. So this is the result of cell proliferation and migration. And what you want to note here is the fact that this epithelium is essentially continuous. So these two swellings do not have individual epithelium. They share the same epithelium. In contrast, when we have palatal fusion, or fusion of those shelves, there's a separate epithelium on each shelf. And so those two epithelia will have to break down, and then mesenchyme will fill in, and then the epithelium has to reform so that now we have a smooth surface where the shelves have fused. And what happens if the palatal shelves fail to fuse? This is when we get cleft palate. So cleft palate is essentially the failure of fusion of either the hard or soft lateral palatine processes, either with each other, so again, failing to fuse in that midline, or failure to fuse with the nasal septum and or the median palatine process. And so you can have failure to fuse of one of these things, or you can have severe cleft palate where a lot of these different things fail to fuse. So clefts of the most anterior palate are going to involve the primary palate, or that intermaxillary segment, and clefts of the posterior palate are going to involve the secondary palate. So for example, B would be a better example of a cleft of the posterior palate, although that's pretty significant cleft. So here in this cartoon you see some cleft lips and some cleft palates, and of course this child shown here on the right has a very distinctive cleft palate. And as I mentioned on Tuesday, cleft palate can occur by itself, or it can occur in combination with cleft lip. So I just want to spend a minute talking about the development of the nasal and oral cavities, because this is related to the palate. So here I'm showing you an embryo as its beginning head folding, and recall we have that oral pharyngeal membrane, shown here as the buccopharyngeal membrane, where we have that endoderm and ectoderm that are just juxtaposed without any mesoderm in between. So as that membrane is rupturing, starting the process of face and head development, the nasal pits are going to start to deepen. And those median nasal processes that we talked about before are going to merge to form this nasal sac. And eventually they form what's called the nasal fin, which is an ectodermal thickening. That nasal fin becomes the oral nasal membrane that I've colored here in red. At the same time, or roughly the same time, the primary palate is forming from the median nasal process, and I've colored that here in green. The next thing that happens is that oral nasal membrane is going to rupture. And so now we have that primary palate that's formed, and it's going to be partially separating the nasal and the oral cavities. But you can see there's a big gap, of course, back by the pharynx. So the next thing that's going to happen then is that the secondary palate is going to complete the separation of the cavities. So now we have a nasal cavity that's lined by respiratory and olfactory epithelium that's separated from our oral cavity. We're going to switch directions a little bit now and go back to talking about the pharyngeal apparatus. So first we're going to focus on the pharyngeal clefts, or the grooves, which, as you recall, there are 4 pairs. So these are, again, those indentations or pits between the arches, but this is as if you're looking from the exterior. And those clefts are lined with ectoderm. So the clefts are pretty straightforward, since cleft 1 is the only cleft that's normally not obliterated in development. And of course, what that means is clefts 2 through 4 only persist in abnormal situations. So here I've shown in the cartoon on the right, I've just flipped that image that we've been looking at for the past couple of minutes to correspond with the cartoon on the bottom. So pharyngeal cleft 1 is going to give rise to the external auditory meatus and part of the tympanic membrane. So this is going to be the external auditory tube. And you can see here I've circled this in red. Now let's talk about what happens when those pharyngeal clefts don't form normally. So one of the things that can happen are congenital auricular sinuses and cysts. So these are small sinuses or pits and cysts, which you recall are fluid-filled sacs, that are commonly found in a triangular area of skin anterior to the ear. And I've circled this with this blue oval here. And these are likely to be remnants of the pharyngeal cleft or groove. So here's an example of a child with a preauricular sinus, and this is thought to be a defect, in this case, of the first or second groove. Another thing that can happen is the formation of branchial sinuses, cysts, and fistulas. Lateral cervical fistulas or sinuses are uncommon. They're usually open externally to the neck, and that's the failure of the second groove or sinus to obliterate. And you can see in A, there's an example of an external branchial fistula, and in B, it shows some common locations of these fistulas. So they essentially go anywhere from the anterior border of the sternocleidomastoid, from the tragus of the ear all the way to the clavicle. Here is an example of a lateral cervical cyst. So this is now going to be open to the inside, into the pharynx. This is an internal branchial. It's rare. It's a persistence of the second pouch, not necessarily the cleft, but it's open into an intratonsillar cleft into the pharynx. So here's what that looks like in real life. So on the left, you can see a child with just looks like a little bump in his neck. And then here on the right, you can see an image showing that fistula. So you might want to think about what kind of problems this might cause, and then again, what do you have if it's continuous with the outside of the neck? All right, back to our pharyngeal apparatus. Let's talk about the pouches. So again, there are 4 pairs of pouches. So the pharyngeal pouches are going to form as essentially pits that are going to be between the arches. So these are internal to the pharynx, and their linings are endodermal in origin. So the pouches, more than the clefts, give rise to more critical structures during development. And so most of the derivatives I'm talking about today are going to be bilateral, but there are variations, and this is in particularly true with the parathyroid glands. The thymus has bilateral characteristics, even though it fuses on the midline when it reaches its final position. So the first pharyngeal pouch that's shown here is going to give rise to the middle ear. So the distal part of that pouch, together with the lining of the first cleft, is going to form that tympanic membrane, or the eardrum. And that's going to widen and form the whole tympanic cavity, which is that middle ear cavity. And the proximal part is going to stay narrow, and that's going to form the eustachian tube. I have that circled on the cartoon in B, shown in yellow. The second pharyngeal pouch gives rise to the lining of the crypts in the palatine tonsils. Now the tonsils themselves are composed mostly of mesoderm, but the pouch will form the crypt lining, so that's epithelium, and that will be continuous with the lining of the mouth. And of course, these tonsils are involved in the immune response. So this is one of those cases where first aid is actually incorrect. So they argue that this pouch gives rise to the entire palatine tonsils. This is not true. That said, if you happen to see that on a board exam and your only choice is the tonsils, you should pick the tonsils. What about the third pouch? The third pouch is a little more complicated. It's going to give rise to the inferior parathyroid glands and the thymus. So there's two wings of this pouch. The dorsal wing, which is shown in yellow, is going to give rise to the inferior parathyroid glands. And they're, of course, going to be important for regulating body calcium and phosphate levels. The ventral wing, shown in red, is going to give rise to the thymus. And the thymus produces T cells, and as you know from Dr. Williams' lecture, is part of the immune system. So one of the things that's important to note here on this figure in B is that the inferior parathyroid gland starts off superior to the superior parathyroid gland. And the reason it ends up inferior is because it's going to actually travel down with the thymus before it moves over to the thyroid. And I'll show images of that in just a minute. That fourth pharyngeal pouch also has a dorsal and a ventral wing. So it's going to give rise to the superior parathyroid gland and the ultimobranchial body. So the dorsal wing, again shown in yellow, is going to give rise to the superior parathyroid glands, which again are going to regulate body calcium. The ventral wing is going to give rise to the ultimobranchial body. And this is a structure that's going to contain parafollicular cells, or C cells of the thyroid, and those are very important for regulating calcium levels via calcitonin. So that fourth ventral pouch is sometimes considered a fifth pouch that merges with the fourth pouch, but we're going to call it the fourth pouch here. So just to also remind you that parathyroid is going to increase calcium levels and calcitonin is going to reduce calcium levels. So one of the most interesting things about the development of these glands in the neck is that the primordia don't actually originate at their mature functional sites. So they actually originate up in the pharyngeal arch area, and then they're going to need to migrate. So for example, the thymus on either side is going to migrate down to the midline, and then it will fuse once it gets down there on the midline. Then the inferior parathyroid is going to travel with the thymus, again, down to eventually to the thyroid, and then it will essentially migrate over to the thyroid. And the superior parathyroids also migrate down to the thyroid, and as well as the ultimobranchial body. And so I've shown you here animated on the left, and then on the right is essentially saying a cartoon that is essentially saying the same thing, but I think it better illustrates the repositioning of the inferior and superior parathyroid glands. And then I've also linked here to a video where you can start at 2 minutes and 40 seconds where you can actually watch this migration. All right, as probably expected, there can be abnormalities that are resulting from the defects in migration of these particular tissues. So you can have what's called a cervical thymus or a persistent cord. And so this is essentially when you have tissue that's left in that path of descent. And that's pretty rare. It's shown here in brown, and I've boxed it in. You can also have formation of an accessory thymus. So this is just going to be a piece of thymus that's going to remain along that path of descent. And I've shown it up here above the thyroid, but you can actually have accessory thymic tissue anywhere in the path of descent. And then the image on the left is showing a mass, which turns out to be an piece of accessory thymus. So most of these anatomical abnormalities or problems with migration of these glands are benign. So you can have an undescended parathyroid gland shown here on the left. You can have, as I showed you, accessory thymic tissue or persistent cord, or you could have an ectopic inferior parathyroid gland. And these would be, although most of these are rare, these would be the most common abnormalities that are seen. So a major anomaly that's associated with the pharyngeal pouch is DiGeorge syndrome. So this is a deletion of part of chromosome 22, and it's essentially a failure of the third and the fourth pouches to differentiate into the thymus, the parathyroid gland. There's also abnormal morphogenesis of the cardiac outflow tract and the great vessels. So this is again thought to be a neural crest defect. It can be sporadic. There may or may not be a genetic link. It also can be caused by teratogens. It's not entirely clear what the cause is. But we do know that it's variable in severity and outcome. But again, it's a syndrome, and so you rule in a syndrome by looking at a bunch of different symptoms and trying to determine whether the patient has, a certain amount of these syndromes. And again, these deficits have a nice little mnemonic called catch-22. So C is for cardiac abnormality. A is for abnormal facies. So again, this is neural crest defects, so their faces don't look absolutely normal. They have thymic aplasia. They can have a cleft palate. And they have hypocalcemia or hypoparathyroidism, again, due to the fact that they don't have a parathyroid gland. And so they have kind of, characteristic facial features, and they have very characteristic heart features. And again, because this is a syndrome, the symptoms in these patients can vary, but they almost inevitably will have the cardiac abnormalities and the thymic aplasia. So what do we know about the cardiac abnormalities? So here's an example, just a cartoon showing the normal heart on the left and what is known as tetralogy of Fallot that is commonly associated with DiGeorge syndrome, where you have an overriding aorta, pulmonary stenosis, a ventricular septal defect, and a resultant right ventricular hypertrophy. All right, this slide just shows a summary of the structures that arise from the pharyngeal pouches, and I won't go over it again, but again, this little picture on the bottom actually is a repeat in part of the big table that I showed you yesterday, but again, we all have now layered in the derivatives of the pharyngeal folds. Those will be the clefts or the grooves on the left, and the pharyngeal pouches on the right. So finally, we'll talk about the membranes or the closing plates of the pharyngeal apparatus. So again, these are those locations where, in the pharyngeal arch, where we don't have any mesoderm in between the endoderm and the ectoderm. And that's called the closing plate or the membrane. So again, forming where the epithelia and of the pouches and the grooves approach each other. So the most important structure that arises from the closing plate or membrane is the tympanic membrane, and it's derived from the layers between the first cleft and the first pouch. So how does this actually happen? So again, pouch 1 is going to form that primitive tympanic cavity, so that's going to come in from the endodermal lining. And then we have from cleft 1, we're going to form that bottom of the auditory meatus. And then what happens is we have neural crest that moves in between, and eventually we form our tympanic membrane. Now the remaining closing plates or membranes between the arches, they don't stay as membranes, but they essentially become obliterated during development. So they're lost in the adult. I'd like to discuss ear development for a few minutes, because as I mentioned yesterday, a good part of the ear is actually formed from derivatives of the pharyngeal arches. So let's talk about the middle ear first. On the left, we have that cartoon that I showed you yesterday showing the derivatives of the cartilaginous rods from the arch. And the ossicles are formed from both first and second arch cartilage. So the incus and the malleus are formed from arch 1 cartilage, while the stapes is formed from arch 2 cartilage. Then, as I just showed you, the tympanic membrane is formed from a combination of the first cleft and the first pouch membranes, and then later neural crest moving in. And the tympanic cavity, shown here in B in yellow, and the internal auditory meatus come from that first pharyngeal pouch. So again, here's an example of the entire ear. The outer ear actually develops from the first and second arch, and that the external auditory canal is forming from the first cleft. And I just went over the middle ear, but again, ossicles from the first and second arch cartilage, the tympanic membrane from the first membrane, and the auditory tube from the first pouch. Only the inner ear is not derived from the pharyngeal arches, but develops entirely from the otic placode. So here's just a mini summary of what I've talked about for the last 2 lectures. Again, we have 5 arches, clefts, pouches, and membranes. They give rise to much of the face, the oral cavity, and the pharynx. And there's a very simple and repeated metameric embryonic pattern that then elaborates, meaning the stuff goes everywhere. And again, thinking about duplications of gene families and different combinations of genes expressed in tissue, including the Hox genes, underlies this elaboration of the vertebrate body plan. So I want to end today by talking about the development of the thyroid gland. So the thyroid gland is forming from this endodermal diverticulum, which is just posterior to the floor of the first arch, around that foramen cecum, right? That's about where it starts. So it's important to note that this is a pouch or a diverticulum, but it's not a pharyngeal pouch. So it's not bilateral. Unlike the thymus, which forms bilaterally and fuses on the midline, the thyroid gland originates on the midline. And that diverticulum is going to elongate into a duct called the thyroglossal duct, the thyroid tongue duct, if you will. So that gland is going to remain in contact with the tongue early on, but it will be normally obliterated later in development. So the thyroid gland is going to originate near the tongue, and then it's going to migrate down to its final position on the anterior of the trachea, which is shown here in the image on the right. And as we've discussed in our endocrine classes, the thyroid regulates metabolism, sensitivity to hormones, and a whole wide range of body functions. So let's look again at the migration of the developing thyroid gland. So I have a little pink circle here on this diagram that marks the origin of the thyroid, so that foramen cecum. And then it's going to migrate down to sit on the anterior of the trachea. Now here I'm showing the root of the thyroid gland in orange, but I'm also showing you locations of possible malformations or abnormalities with the migration of the thyroid gland. So each of these orange circles is representing a potential location of a thyroglossal cyst. So again, what are cysts and what are sinuses when they're related to the thyroid gland? They're failure of that thyroglossal duct to completely pinch off and degenerate. So again, they can form anywhere along that course on the previous slide, so anywhere where that duct is going. Most of these are identified by about 5 years old, and for the most part they're asymptomatic, but they can get infected. They're almost inevitably in the midline, and they're painless, and they're movable. And again, sinuses are open, cysts are closed. So one of the things to think about the difference between a persistent thymic duct and a persistent thyroglossal duct is going to be location. The thymic ducts are going to be more lateral because their migration pattern, and that thyroid gland is migrating straight down the midline. So it is going to be, those cysts will be also in the midline. So here's an example of a failure of just the most anterior part, the originating part of the thyroid to actually degenerate. So that just the top of the duct there on the tongue. And then here's an example of another thyroglossal duct. So again, if you go back a couple of slides, you can see the difference where you would have a fistula or a persistent thymic duct on the lateral edges of the neck and a thyroglossal duct along the midline. So again, here's just showing you that same pattern of where you can have the different cyst or sinus locations. So these 4 circles actually happen to represent the most common areas that cysts are seen in. And here on the right, we have another patient who has a thyroglossal duct abnormality. So let's talk a little bit about ectopic or heterotopic thyroid. So here I'm showing you a cartoon on the left that shows several of the different locations shown in green where you can have ectopic thyroid tissue. So again, anywhere along that thyroglossal duct. On the right, we see a patient who was diagnosed with ectopic or heterotopic thyroid, and his imaging is seen below, where you can see the arrows pointing out the different regions of ectopic thyroid tissue. So again, This can happen anywhere along that thyroglossal duct. If you have a total migration failure, then the only place you're going to see ectopic thyroid tissue is going to be in the tongue. The most common region for ectopic thyroid would be either sublingual or lingually. And again, you can imagine that ectopic thyroid could cause several different problems, particularly if that thyroid tissue is actually active. All right, so that's all for the remainder of the pharyngeal arches. Please feel free to contact me if you have any questions about this material. Thank you.